Hello, everybody. Welcome to Tuesday VMR. I'm delighted to be discussing a case today. Our case presenter is going to be the one and only Hemun. And before we get underway, I'll have her introduce herself. And then also we have the fabulous Kirtan Patolia, who will be co-discussing with me today. So before we have the case presented, we'll have Hemun unmute and just say hello. How are you, Hemun?
Yeah, I'm doing great. It's my honor to present the case to amazing teacher Dr. Ravi and Dr. House in clinical problem solver Curtin. So I'm very excited. Yeah.
Absolutely wonderful. I really appreciate you bringing a case to us today. And Kirtan, how are you?
Hi, Dr. Singh. It's all good. Last time I discussed case with you was probably like 2 months ago. In the last week of June, I think we discussed two of the cases, and now we are discussing again. So it's always nice to get back with you. Reminds me of old days when we used to discuss more frequently. And of course, thanks to he for presenting the case. I just talked to he like a couple of weeks ago on phone, and it's always fun that when you talk to people and you get to know them, you get their perspectives, and then they present a case or like you see them inside the medicine and you see them outside the medicine. So it's always so good. So it's always fun in CP solvers. You like talk to friends and then you discuss cases with them. So I'm super excited for today's case. And unfortunately, we don't know who will be doing the teaching points today, but at least we know that who is going to help us doing the scribing. It's going to be Bayan. So maybe we can ask Bayan to unmute and tell us how has things been going with her. Hi, Bayan, if you can unmute.
Yeah, hi everyone. I hope you're all doing well. Um, just I'm currently on pediatrics, which is a huge change for medicine. A lot of people say pediatrics is medicine for the little ones. It's not. So I'm glad to be back in the medicine world, in the internal medicine world.
That's fun. And for how long you will be on pediatrics?
Just till the end of the month, so about 10 more days.
Nah, I mean, pediatrics is so fun. I remember during med school when we had pediatric rotation, like you see that it's so challenging to interact with the kids. And it's like responsibility of two people that you actually talk to the parents and then kids. So it's like two patients, and based on the data you get, you have to figure out. So it's so humbling to be pediatrician. So yeah, glad that you are getting that exposure. And yes, thank you for scribing for us today. And maybe Himun, we can get started with the first aliquot and then we can change the aliquots with Dr. Singh. Yeah.
Sure. Let's start. Chief complaint is palpitation and shortness of breath for 2 weeks. HPI, a 38-year-old woman, 8 months postpartum after complicated preeclampsia-related early delivery, present with a progressive shortness of breath, palpitation, euthymia, and paroxysmal nocturnal dyspnea, along with a bilateral lower extremity pitting edema. I will stop here.
So, Kirtan has asked me to start off with the first aliquot. Usually I invite my good friend to kick things off, but Kirtan, a couple of really interesting features here. I think if we highlight there's palpitations, there's shortness of breath, and then we'll tackle the history. So let's do this. I'll tackle the palpitations, and then you take the shortness of breath, and then we'll see what's common between them. So before we dive into palpitations, I think the knee-jerk reflex to think about palpitations is usually the heart, and palpitations may be due to some sort of arrhythmia. But I also like to think about what could mimic palpitations. Obviously, I think with shortness of breath, the heart, the lung system, there's something going on there. But how about let's think about mimics of palpitations. So certain organs that are neighboring the heart could cause palpitations or the sensation of palpitations. So one could be the esophagus. So esophageal spasms can actually mimic palpitations. Sometimes with the esophagus and then the stomach can actually have awful reflux, and that also can cause what we call pseudo palpitations. And then neighboring that, you could have a hilar hernia, which also could cause this sensation of palpitations. and then other things that surround the heart, the intercostal muscles, and you could have twitching of the intercostal muscles, which could mimic palpitations. So that's the landscape of pseudo palpitations. Let's get into the nitty-gritty of palpitations. So what are palpitations? It's when a patient has this unusual awareness of the beating of their heart, and it's very unnerving. It could be like a rapid, fast beat, it could be fluttering, it could be flip-flopping, it could have many different sort of characteristics that the patient may mention. And red flags that associate with this, I worry about like chest pain. If you have chest pain, this is not a good sign. If you have associated hemodynamic instability, lightheadedness, you could have dizziness. This is also not a good sign because that means the heart or this palpitation or this arrhythmia is causing some sort of compromise, maybe lack of blood supply to the heart, maybe coronary artery disease, ACS, lack of blood supply to the brain, and you get lightheadedness and so on. If you get loss of consciousness, even a worse outcome of this. So these things you have to be very worried about. And you could have something that could be a prodrome to this, which could be also near syncope that you would worry about. Other questions to ask, I would ask, does this patient have family history of sudden cardiac death? That could be a red flag. And any history of arrhythmias in the past as well. If we then just lastly, I don't want to keep rambling on, but if we break down palpitations, what the types that we worry about, arrhythmias, there's non-arrhythmia causes, there's non-cardiac causes, which could be outside the heart, like certain medications, drugs, coffee, and then there could be psychiatric disorders like anxiety, which you want to, it's a diagnosis of exclusion, but that definitely could cause palpitations in a patient. And I'll flip it over or flip the mic over to Kirtan to talk about integration of this with shortness of breath.
Perfect. Thank you, Dr. Singh, for emphasizing that although when we hear the chief complaint, everything screams that something is wrong with the cardiovascular system and heart, but you laid down important points that how structures surrounding the heart and other aspects of the body can also end up causing palpitations. So we should scrutinize the other aspects of the case closely before kind of attributing everything to the cardiovascular system. So you describe palpitations very well, so I can maybe talk about the shortness of breath. So we know that when you have dyspnea, the two main aspects which we deal with is it exertional dyspnea or is it the dyspnea at the resting state? In many disease states, you tend to have dyspnea in both the conditions, resting as well as exertion. And in some conditions, it's only with the exertion that you start having issues. And although we try to neatly define the differentials that if it's exertional, maybe it's more likely to be the cardiovascular system involvement. And if it's only at the rest, then maybe it's the lung involvement. But we know that disease pathologies kind of overlap. And in the end stages, even severe ILD can end up causing dyspnea both at rest as well as exertion, right? And similarly, if there is severe heart failure, you can have dyspnea at the rest as well as exertion. So that component of history may not help us much, whether it is exertional or non-exertional. But if we think about the other aspects which we have, like there is orthopnea, paroxysmal nocturnal dyspnea, edema. So we have so many clues which point towards the heart being involved rather than the liver or rather than the kidneys being involved. So once history is suggestive more of the cardiologic involvement, we try to figure out that what could be doing that in our case. And this is very important aspect of medicine, right? That how important it is to have one liner and how important it is to have the context. Like if I tell you that we have a 40-year-old gentleman who has extensive alcoholic history and who is now presenting with 5 days of shortness of breath, immediately we will start thinking that could this be related to alcohol, like alcoholic cardiomyopathy, or could it be related to the nutritional deficiency, like thiamine deficiency causing cardiomyopathy? Similarly, if I tell you that we have a 25-year-old young lady who is presenting with 5 months of weight loss, hair loss, palpitations, ptosis, like proptosis, and now is presenting with heart failure, immediately we'll start thinking, could this be thyroid dysfunction? So like you could imagine that how context is so important. And in this case, we are seeing that we are dealing with a postpartum woman, and especially the pregnancy, which was complicated. It was like pre-eclampsia. And now, like within 2 to 3 months, we are seeing that patient is presenting with this fulminant symptoms. So it's hard not to entertain the possibility that could this cardiomyopathy be related to some kind of peripartum complications, some pregnancy associated issues, right? And often in reality, what happens is that we try to find the pointers to navigate our way to the end diagnosis. And that is important. That is like type 1 thinking. But as Dr. Singh emphasized earlier on, that we will do that kind of workup, but we don't want to miss any other entities which could be going on in a young person. So for example, what are the other things you want to consider when someone has heart failure in a young person? First is you always want to take a look closely at their medications. Like what are the medications they are prescribed? If they are on certain antipsychotics, then we know that they can end up affecting the heart. If they are on certain antidepressants, they can end up affecting heart. Then Dr. Singh was saying, what about arrhythmias, right? Is this patient on any of the medications which could end up causing arrhythmias? And when I use the word medications, it's not just prescription medications. It's also the medications which people might be taking recreationally. What if I say that we are dealing with a 45-year-old gentleman who has been cocaine and amphetamine abuser and now presenting with acute onset of shortness of breath, chest pain, and lower extremity edema? Immediately we will start thinking, could this be drug-induced MI or drug-induced myocarditis, right? So context is important. That's why in this case, we want to know the drugs which patient has been taking, any prescribed medications or not. And once we have that basic data, we can try to make more progress. Dr. Singh, anything to add before we go to the second aliquot?
Yeah, I think you've married both of these different domains together very well. And I think at the center of this, the 38-year-old and then the preeclampsia. And I guess in the next aliquot, we'll explore this further. But I think these two complaints, we've started off very well as to how to think about these both of these different complaints. And then we'll see what's in the further history for this patient. Hemon, back to you.
Yeah, amazing discussion. The teaching point half is filled. You guys awesome. Yeah, so the Dr. Ravi's question, a sudden cardiac death in family was not seen there and no arrhythmia in the past. The patient also report tremulousness and chronic diarrhea and abdominal pain and unintentional weight loss over the past 2 to 3 months, but no chest pain and yeah, no arrhythmia in the past. And also social history, she doesn't drink alcohol and she doesn't do smoking, no cocaine or no substance abuse, no substance use. And yeah, any medication related with arrhythmia, she's not taking any medication related with arrhythmia. And also, I will give you vital sign and physical exam. Vital sign temperature is 37, heart rate is 150, blood pressure is 96/72, respiratory rate is 23, saturation is 92%, general ill appearing, HENT, mild exothalamus, large, soft, non-tender anterior neck mass with a visible dilated surface vessel, cardiovascular tachycardia, irregular rhythm, and no murmur, rub, or gallop, no JVD, pulmonary, bibasilar crackle, no wheezing, equal air entry bilaterally, abdomen soft, non-tender, mildly distant, no hepatosplenomegaly, extremity bilateral pitting, lower extremity edema, neurologic, no focal deficit, fine tremor, note in outstretched hand. I will stop here.
Perfect. Thank you, Himan, for kind of giving us all the data very efficiently. And I will like to clarify just one point, that this diarrhea, tremulousness, all of them started right after the delivery, or was it present even before the delivery?
No, it after the delivery, 2 months later. So she is 8 months postpartum. So it was like after giving birth, and a few months later, she started to have those.
Perfect. Thank you so much. So maybe I can tackle this aliquot first, and then we can ask Dr. Singh to share his thoughts. So if we have to summarize, we are dealing with a 38-year-old lady who is presenting with chronic symptoms characterized by diarrhea, tremulousness, and has now been presenting with subacute course of lower extremity edema and dyspnea. So as we were talking in the first aliquot, that although everything kind of will make you think that, well, it started after the pregnancy, could this be related to the pregnancy? And it is easy to entertain that possibility, but we also have to figure out the other aspects. So as we are saying that context will matter, right? So like just as we were like laying down all the scenarios that what if this person has weight loss, hair loss, will suddenly start thinking the thyroid disease, right? And now looks like that we have some signs pointing in that direction, that you have tremorlessness, you have chronic diarrhea, right? So all these symptoms are kind of non-specific, can happen in so many scenarios. But if we, like what Dr. Singh focused in the first aliquot was palpitations, and if I just talk about the tremors, then if you start thinking that what tremors actually mean, right? And tremors is like kind of like a neurological thing, right? As soon as we hear the word tremors, we like start thinking that, oh my God, will I be able to figure out the cause? Would it be basal ganglia? Would it be cerebellum? I don't know, all kinds of tremors. That's totally fine, because like tremors is like such a nuanced topic that it's very hard to figure out that what tremor exactly is, unless you have been experienced enough to see the tremors with your own eyes, right? But in reality, in medicine wards, when you see the tremors, the first and foremost thing you want to know about is that, is it driven by the excessive sympathetic tone in the body? Because when you have so much stimulation of the adrenergic receptors, especially like the beta 1 and beta 2 receptors, you can end up getting the fine tremors. So in this case, like given that the patient also has other signs of excessive sympathetic drive in the form of tachycardia, in the form of like palpitations, right? So you start wondering that, well, maybe I'm trying to solve a problem which involves excessive sympathetic drive in the body, right? So that's the first part I wanted to clarify. Now, second thing is chronic diarrhea. Now, again, if you go down the algorithmic approach of chronic diarrhea, you will have like 20 different causes, like so many classifications. But in the context which we are dealing with, if you kind of try to simplify it, when there is excessive sympathetic drive, what happens is that you end up causing sometimes increased motility and increased secretions as well in the GI tract. And that is what can be driving the diarrhea. So that part is important to keep in mind. Now, talking about the weight loss. So weight loss basically means that there is imbalance between the anabolism and catabolism. So when the catabolism wins over the anabolism, you end up getting the weight loss. And many differentials exist for this imbalance, but in a young person with no other like signs and symptoms which are dangerous in like nature or like red flags, you start wondering if this could be endocrinologic problem or autoimmune problem, right? So in our case, since we have built up the case for excessive sympathetic drive, you start wondering if excessive thyroid levels in the body might be contributing to excessive catabolism or not, right? And then if we start thinking about the physical examination, first and foremost thing is that the patient is like very tachycardic. So, and based on EKG, I mean, we don't have EKG yet, but based on what Himun told us that this is irregular rhythm, we start wondering if this patient can have atrial fibrillation, right? And one quick point which I wanted to mention here regarding the management is that often we try to think that if in atrial fibrillation, heart rate goes above like 110 or 120, maybe we should try to employ the rate control strategies. But in reality, like these decisions are very complex to make, and they are often context driven and patient based. But some of the teachings which I myself have learned from the VMRs from Ravi is that usually you don't want to do the rate control unless first patient is extremely symptomatic, like extremely uncomfortable, that you can visibly see that they like cannot even talk. Then you may want to try to control the rate and make them feel comfortable. Second thing is that if you think that this atrial fibrillation is causing hemodynamic instability. So in our case, the blood pressure is 96/70, which is kind of what we would describe as the softer blood pressure, but the mean arterial pressure is still, I think, above 65, enough to perfuse all the organs. And we are not seeing any signs of end organ damage yet. Like we haven't heard that patient is confused or like AO times 0, right? We haven't heard that patient has extremely high lactate. We haven't heard that patient is oliguric. So if all those signs and symptoms of end organ damage develop, then we start thinking that should I control this AFib or not, right? Even in that case, you want to control the rate control AFib only if you think that by reversing the AFib to sinus rhythm, the hypertension will resolve. So how to make the decision that AFib is really contributing to hypertension or not? So in general, AFib contributes to hypotension only if you have like severe constrictive restrictive physiology in the heart. So in case we come to know that this person, let's say, have constrictive pericarditis or like severe restrictive cardiomyopathy, then what happens is that in those states, the left ventricle relies a lot on the last phase of the atrial contraction through which enough blood comes into the heart and then you maintain the perfusion. So if you have AFib, you won't be able to do that and your hemodynamics will suffer the blow, right? Or on the other side, if you have severe valvular disease going on, especially like mitral regurgitation, then also the atrial kick is very necessary to maintain the perfusion. So unless you have these three scenarios going on, like patient is extremely symptomatic, or second, end organ is compromised with severe consecutive restrictive physiology or mitral regurgitation, you should not try to give beta blockers just for that purpose to achieve the rate control. And this is like in general for any kind of AFib. So I just wanted to lay down that pathway. And maybe now I can ask Dr. Singh to kind of tell us more about other examination findings and how it ties up to other symptoms we have discussed so far.
Absolutely. Wonderful job there, Kirtan. I think here there's an obvious cause here which we can just sort of what do we say, pattern recognition will lead us to the thyroid here. But we kind of have to be careful because, I've seen many cases where something's obvious, but we then miss something that sort of blindsides us, and it can actually cause adverse outcomes for patients. And that's why we come here. That's why, my friend, we are discussing it today. That way, when we go to manage patients, we do not commit this grave mistake of ignoring other diseases or other conditions. And I think we have to do our due diligence to any patient and explore the vast landscape of what could be causing these conditions. So I think what you really have focused or centralized here is the heart, right? So the heart is showing decompensation by orthopnea, PND, edema. So the heart, the pump is compromised. And here with postpartum, with the postpartum condition, what kind of things could affect the heart? So, postpartum eclampsia, if you have high blood pressure, you can develop over time left ventricular diastolic dysfunction, hypertrophy, and so on. So that could explain this. Second thing could happen is, I love this catecholamine surge that you can get, these tremors. In a young person, tremors could be mostly this. You take in too much coffee, you take in too much Red Bull or something, and then you have tremors. In an older person, I would say mostly it is the basal ganglia cerebellum, but you could get some pathology happening earlier on though as well. And so sympathetic overdrive, I talked about this in a case recently with pheochromocytoma where you can get this. So, but here we have a distinct alternate endocrinological mechanism happening as well. What else can pregnancy do to the heart? We talked about arrhythmias as well. What are the most common arrhythmias that you could get? What is the most common? Probably is SVT, and then atrial fibrillation. Atrial fibrillation happens with any sort of things that can happen to the heart or externally to the heart, like thyrotoxicosis. Also, medications or drugs. And notoriously, nowadays, we have so many over-the-counter and also drugs that are brought in from abroad for weight loss and can have devastating side effects. And then what else could affect the heart? Postpartum, hypercoagulable states, but usually that would happen within the vicinity of the delivery or the pregnancy state. Wouldn't happen months down the road. And anemia can happen, we know about, right? So anemia can cause this too. One interesting thing, when we just take that irregular rhythm, if we think about or we anticipate, what is the EKG going to show us? Yes, atrial fibrillation. It could be, what else could we get? We could get SVT with aberration, can cause irregular rhythm. And in this case, most likely it will be, I anticipate AFib if we're thinking about the thyroid here. And if we think about the neck mass here, we're probably talking about maybe goiter, maybe a multi-nodular goiter, which could be toxic in this case. We would need to do testing as well. What could a goiter do as well? If you look at the vicinity of the location, if you think about it, it can compromise vascular flow. So Human described like a lot of vessels around there. There's exophthalmos as well. So you could actually get some vascular compromise in the head neck area as well. So almost like a SVC kind of syndrome, but more the internal jugular and so on. But they always say, like, it's interesting. You take you take your scope and you put it on on the um, the thyroid, and sometimes you could hear a bruit occasionally, and that could be a physical exam finding. So that would be interesting if this was done, because again, you need a lot of blood supply to the thyroid as well, when it has grown this much, because it's very hypermetabolic. Other than that, I think, yeah, looking at all the different conditions surrounding pregnancy, there's so many complications that can happen. But I think here probably you have pregnancy-related hyperthyroidism. And what's interesting, if you look at the time frame, initially I was thinking maybe postpartum cardiomyopathy. We had a case where it was a year out. Usually it's like 6 months, I think, out from pregnancy, the delivery, but here it's a year out. So that still could be a viable hypothesis. When you have postpartum thyrotoxicosis, that usually can happen 6 months, 9 months, years. So this does fit that time frame. So it is very much a plausible hypothesis in this case. So further diagnostic testing is necessary. We need to do antibody tests. We need to do imaging to see and at least get first TSH, I think, to kick things off with. Anything else, Kirtan?
No, Dr. Singh, I agree with you that we will need certain labs. And I think if we think more about what kind of things we would need, apart from the basic workup, one very important thing when we are dealing with AFib or aflutter is to determine if it is valvular or non-valvular. That's the main thing that you can always try to find the cause, like, is it from thyroid? Is it from drugs which you are taking? Is it from underlying cardiomyopathy, underlying coronary artery disease? But the main thing is it valvular or not? So in a young person, you always wonder that can they also have underlying valvular pathology, which was exacerbated by thyroid storm, which is going on, right? So I guess getting the echo also would be absolutely crucial down the line to answer this key question. Of course, we want to know the ejection fraction and all other aspects. So let's see what Himoon has in store for us.
Yes, as you wish, I will give you an answer for that. Yeah, so the lab, WBC 15K, hemoglobin 10, platelet 120K, sodium 132, potassium 3.2, HCO3 20, BUN 30, creatine 1.4. So creatine was normal, so it's increased. AST 90, ALT 55, glucose 180, lactate 5, ESR CRP mildly elevated, chest X-ray, cardiomegaly with a bivascular infiltrate, EKG, atrial fibrillation with RBR, bedside sono, hypervascular thyroid, and we did just in case the pregnancy test, beta HCG was negative, and TSH was 0.01, FT4 is 6, TT3 is 330, BNP was 3021, troponin not elevated, TR antibody 20 positive, echo severely dilated left ventricle, ejection fraction was 30%. And I will stop here. And blood culture and urine analysis, everything was within normal limit, and the respiratory blood culture was negative.
So thank you, Heman, for delivering those labs so wonderfully and concisely. I think we have the labs we need at this point to definitely rule in thyroid-related conditions. So as you see here, the TSH is very low, free T4 is 6. And if we look at the antibodies here, so you want to do antibody testing, and certain antibodies like you could do the anti-TPO, and you can do the thyroid stimulating and the immunoglobulin. And here the TRAB20 being elevated is showing that this is a autoimmune thyroid related condition. So looking at the other labs, I think the white count 15, this can be an inflammatory related condition. The ESR is elevated as well. The chemistries, there is a mild hyponatremia. The patient's in, you would say, congestive heart failure, volume intravascularly, volume depleted, extravascularly, volume overloaded. So sodium's likely related to that as well. I'm not sure. There was no meds that she was on, maybe like a thiazide diuretic or something that could cause hyponatremia. So I don't think we're dealing with anything here like a beer drinker's potomania or a tea and toast diet or primary polydipsia. But the echo showing severely dilated LVF 30%. So this is what we initially had anticipated with the just the complaints of PND or orthopnea. These have a very high likelihood ratio for congestive heart failure, especially right-sided congestive heart failure. I don't remember if we had a JVP, but a JVP would also increase the pretest probability for congestive heart failure in this patient. And the X-ray does show bilateral congestion. So as we know that thyroid does have some conditions on the heart. So thyroid hormone itself can cause changes in the myocytes of the heart and can lead to this cardiomyopathic state. So number one, the thyroid can affect the heart through the rhythm. So conduction mechanisms can directly affect the contractility as the myocytes become diseased over time. And then also the vascular system also can get disrupted by by thyroid as well. So underthyroid bradycardia can also cause cardiac dysfunction. And too much thyroid can overstimulate and over time cause this cardiomyopathy as well. So you do need a balance of thyroid to allow the heart to function. The thyroid has vast implications on the whole system of the body. So it's such an important hormone in daily function. And you can see here an abundance of thyroid can wreak havoc on the vascular system as well as the heart. So here, what's interesting, we have to manage, yes, the thyroid in time. In addition, this arrhythmia, this heart rate of 150 is also, it can actually cause its own set of conditions. You let AFib fester, 150 beats per minute for a prolonged amount of time. Somebody had put in the chat, Takotsuba's cardiomyopathy. So excess sympathetic effect on the heart over time can cause cardiomyopathy. So in itself, AFib with RVR can actually set up a vicious cycle. Cardiomyopathy, AFib, worsening cardiomyopathy, and with atrial fibrillation, you also get remodeling of the heart too. You can get the conduction system develops memory, certain reentry or certain mechanisms where the impulse can just continue to circulate and perpetuate AFib. So the longer you're in AFib, it's very difficult to come out of AFib. Muscle memory, even the myocytes remember AFib and the way it conducts. And then there's channelopathy, and then fatigue, and there's so many implications. You can read a whole textbook on how the heart suffers under atrial fibrillation. So it would be imperative to treat this as well, because a cardiomyopathy, a heart with cardiomyopathy will be very symptomatic with atrial fibrillation. So controlling atrial fibrillation or even normal rhythm in this case. So we talk about rate control, rhythm control. Rhythm control may be imperative to allow this heart to function at least somewhat normally. And then from there, we reverse the thyroid effect on the heart. Over to you, Keaton. I think I talked a lot.
No, that's perfect, Dr. Singh, what you said. So, friends, as we were discussing in the previous record, that like in like general, like in medicine, there are always exceptions, right? In general, what we were saying was that if you have AFib and if patient is otherwise doing fine, you don't just run to control their rate. But in this case, like as Dr. Singh said, that there are some intricacies, right? That whenever there is AFib, you always want to try to fix the underlying cause, and we will try to fix the underlying cause in this, which would help control the rate eventually. But since the whole purpose is the excessive sympathetic drive from the thyroid, we want to give beta blocker in this case. So we will talk about that for sure. But now let me just first focus on the labs. So we have like unequivocal proof that this patient has excessive levels of thyroid hormone in the body, right? There is like high T4, high T3, and TSH is low. So we also know that the main issue is that your thyroid is secreting excessive levels of hormones and which is suppressing the TSH. So we would call this as the primary hyperthyroidism. So we have defined that problem. And now all we need to do before we jump into management is to figure out that what is the mechanism of this excessive level of thyroid hormone in the body, right? So in general, there are two mechanisms. First mechanism is that because of the underlying pathophysiology, maybe you are synthesizing the thyroid hormones excessively within the thyroid cells. So this happens, let's say, for example, in Graves' disease, that you have excessive stimulation of the thyroid stimulating hormone receptor on the thyroid gland, which allows the iodine to come in and which allows the activation of all the enzymes, which results in generation of thyroid hormone from the iodine, and then you release it, right? So this is the excessive synthesis driven thyroid excess. The second aspect is maybe you are not synthesizing excessive thyroid, you are just destroying the thyroid which is already stored in the thyroid follicles. And this is what is known as thyroiditis, right? And we know that there are two main causes of thyroiditis. One of them is like the postpartum silent thyroiditis, and sometimes we can have painful like post-viral decurrent kind of thyroiditis, right? So in both of these cases, regardless of whether it is painful or painless, the mechanism is that you are not synthesizing the thyroid hormone excess. You are just destroying the follicles, right? And this has crucial implications for how you manage. So for example, we always think that when there is thyroid hormone excess, the first drug which comes into our mind is like propylthiouracil and methimazole, right? But if you think about it, you can use those medications only if you have proof that there is excessive synthesis, as in Graves' disease. In people with thyroiditis, you don't use these medications, right? And these medications are not trivial medications. They can have severe side effects, classically the liver dysfunction. So you don't want to use them without figuring out why you have excessive thyroid hormone, right? And how can you make that progress? So one easy way is to look for the antibodies, right? That you can look for anti-TSH receptor antibodies, anti-TSI immunoglobulins. But although when the titers are very high, you might say that it could be Graves. But if titers are not very high, they could be high in thyroiditis as well. So I think the gold standard test, which is recommended, is to actually do the radioiodine uptake scan. Because if you think that is the excessive synthesis of thyroid hormones in Graves, then the iodine scan will show that it will light up. The gland will light up diffusely, showing that iodine is going into your thyroid follicles, right? Whereas if it's thyroiditis, you are just destroying the thyroid, then the iodine uptake would be minimal because actually iodine uptake would be suppressed because you are just releasing everything out. Iodine would be allowed into the thyroid gland. So in this case, getting the radioiodine uptake scan is absolutely essential to figure out what are we dealing with. Is it Graves or is it thyroiditis? So that would be my first step. My second step would be having figured out that I want to do that. Now I also want to focus on the management. So in endocrine world, there are not many emergencies that we see, but this is one of the emergencies. Like this could be thyroid storm. And how can you say you have thyroid storm? Of course, there are clinical parameters. Like you look at the patient and you can say, but is there an objective evidence? So there is objective evidence. So it is known as like BWPS score, which is like the Birch-Wartowski score. Like you can go on MD Calc and you can plug in the numbers based on the age, based on the heart rate, based on the cardiologic dysfunction. And if that score is more than 45, then you have very high risk of thyroid storm. So in this case, like while Dr. Singh was explaining, I was like plugging in the score and the score turned out to be at least 55, even if we don't consider other aspects of the case. So 55 is above 45. So this is definitely thyroid storm. So when you are in thyroid storm, patient could die really fast before even you can get like all these iodine uptake scans and stuff, right? So you want to focus on the management right away. So in the management, what is the key aspect? So first is you want to dampen the excessive sympathetic drive, right? So for that reason, you will give the beta blocker, and ideally the beta blocker of choice would be non-selective one, which would be like propranolol. And the reason being that propranolol has additional effect in the periphery to inhibit the conversion of T4 to T3. And we know that kind of T3 is the main metabolically active iodine at the level of tissues. So if you can prevent that conversion, then it's better, right? So propranolol should be given to this patient definitely. And then before deciding if we want to give them propylthiouracil or methimazole, I think we still need to wait for radioiodine uptake scan. But with propranolol itself, patient will feel a lot better. And then second very important aspect I wanted to lay down is that thyroid and cortisol are kind of like friends, they go hand in hand. So let me give you alternative scenario that if you end up giving thyroid hormone to someone who has adrenal insufficiency, then what will happen is that thyroid will increase the metabolism very, very fast. And if you have even subclinical adrenal insufficiency, you will push them into clinical adrenal insufficiency. That's why people say that when you have hypothyroidism and you want to give someone levothyroxine, you want to make sure that you check their cortisol so that you don't push them to adrenal insufficiency. So this is the alternative scenario. In our scenario, patient has thyroid hormone excess. So you might say that, well, there is already thyroid excess. So yeah, that's the another reason, right? That there is so much thyroid excess. What if you catabolize all the cortisol, right? And maybe that's why you have some degree of vasoplasia, and that's why your blood pressure is low. So in general, in thyroid storm, many authorities suggest that you want to give them steroids as well, along with the treatment of thyroid storm, right? So in this case, I would be, of course, seeking the help from the endocrinologist, but at bare minimum, we should give them propranolol, we should give them like hydrocortisone or like whatever is the protocol, like dexamethasone, and get the radioiodine uptake scan before deciding if you want to give propylthiouracil or methimazole. Dr. Singh, I'm curious to hear from you that what are your management pulse that you have seen based on your experience?
Yeah, absolutely. I think what will be key here, the heart rate, I think immediately to decrease the symptomatology. What I'm going to backtrack a bit. What's interesting, if you think about you mentioned, I liked what I want to springboard from what you mentioned. You talked about thyroid, right? Either you are inflamed and just releasing thyroid that is stored, or you have a mechanism where you're just making a lot of thyroid hormone, like in Graves' disease. So, is this a thyroiditis? And in postpartum thyroiditis, if you look at what was kind of bothering me, so TRAb should be elevated in Graves' disease, right? So TRAb is not elevated, and TSI is not elevated in postpartum thyroiditis. So we don't have the TSI, and I think you're right. Radioactive uptake will help, because if it's thyroiditis, you're not going to have a mechanism of overproduction, so it'll be kind of cold. And if it's hot and it's overproducing, then that would be Graves. So I wonder if, we're thinking like postpartum, right? So patient had preeclampsia and delivered, and around that, the thyroid is on fire, and this is postpartum, but this could be Graves, and this could be what do you call it? The human could blindside us with this condition here. And I think what you mentioned, a key feature here is this a patient with myxedema, or sorry, thyroid storm, and that you would really need to prioritize and treat the patient appropriately. I think here, yeah, definitely, I think the first intervention would be at least beta blockers for controlling the heart rate and also preventing the excessive sympathetic surge that we have here, and then coordinating with endocrinology then to decipher what else to implement in this case. What's interesting, if I remember from thyroid, the postpartum thyroiditis, if you have this inflammation and you are just releasing hormone, at some point you will become depleted, and then you go into a hypothyroid state. And at that point, you will have to then give thyroid supplementation as well. But here, I'm not sure how this will play out. But any other thoughts before we turn the mic over to He?
So no, Dr. Singh, I agree with you that although we will wait for the objective evidence of like radioactive uptake scan to see what kind of thyroid disease it is, but even if you look at the clinical parameters, so like usually postpartum thyroiditis usually comes like within first few months. We are almost 8 months out. And if you look at the fact that patient had exophthalmos, so which is very telling, right? That there are so many causes of thyroid excess, but exophthalmos is almost like kind of very specific for Graves' disease, because it's just the pathogenesis of Graves, right? That you end up depositing excessive glycosaminoglycans and cause fibroblast proliferation in the eyes, which doesn't happen with like thyroiditis or like whatever, right? So if you consider that aspect, I think like this is like very classic for Graves' disease. So, but still we will wait for the final confirmation. And I think eventually we will give them like methimazole or propylthiouracil, and that should be good enough. Yeah.
Great management. Thank you so much. Yes, so we did a Birch-Warsaw score. So it's like a checking fever, sinus symptom, agitation, seizure, and GI liver, like nausea, vomiting, jaundice, cardiac finding, heart rate, atrial fibrillation, heart failure, any trigger like infection postpartum. So the score, the patient was a 70, indicating thyroid storm. And we start on IV beta blocker, hydrocortisone, PTU. PTU was chosen because in addition to the suppressing the synthesis and also prevent it also does peripheral T4, T3 conversion. So instead of methimazole, we use the PTU and iodine, inorganic iodine, iodine. And however, the patient got really deteriorated it. So we didn't, so like usually thyroid storm, if a patient is critical ill, the radioactive iodine uptake test is not recommended. So we didn't do it. And the patient becomes the mean arterial pressure was 55 and ejection fraction was 19. It required cardioversion and norepinephrine and intubation. And she became refractory shock. So the intra-aortic balloon pump was given, and further she deteriorated, so ECMO was given. The lab AST 3031, ALT 1628, alkaline phosphatase 220, bilirubin 4.8, and LDH was over 600. So after this, one or two more allocate, and it'll be finished.
Oh wow, what a change there. And I don't know, Keaton, was it you and me going next? I don't remember.
Yeah, I mean, since we are closing near the time, I will like quickly say that yeah,
Sure.
this is very unfortunate for the patient that despite giving the like emergent treatment, patient seems to be deteriorating more and more. And now our job is to figure out that is it just because of the fact that the thyroid storm itself was so bad that you couldn't have done anything and maybe the treatment is not doing the trick, or are we dealing with something else, right? So as of now, I don't think we have enough evidence to suggest there is alternative pathology going on, but at least like we can do like basic infectious workup, make sure that infection is not compromising anything else. But doesn't seem like that there will be infection. It just looks like that is the natural course of thyroid disease, that as Dr. Singh was saying in prior aliquot, right, that you have so much sympathetic storm, you can end up getting like catecholaminergic surge, you can get like myocardial stunning. That is what happens in Takotsubo, right? And maybe that's why the EF dropped dramatically. And the fact that the AST, ALT, everything is so high is just suggestive of the fact that you have what is described as like shock liver, right? Ischemic hepatopathy, that your blood pressure dropped a lot. And there is so much congestion as well when heart doesn't beat well that your hepatic veins are also like completely choked. And that is why both arterial and venous sides are involved in like perfusing the liver. And that's why you end up getting this liver picture. But another important aspect is that could this be toxicity, right? Like, is it possible that the PTU which you gave, we know that PTU is going to cause fatal hepatotoxicity, right? But like from what I know, although it is an idiosyncratic reaction, it shouldn't happen this fast. So I'm not sure if we can blame the like the hepatic picture just on the PTU toxicity or not. And to be honest, even methimazole causes this toxicity. So I'm not sure if we can just like, even if we blame on PTU, can we give methimazole as well? Probably not, because both of them can do it. So I think that would be my only concern, that is this just the effect of ischemia or is it the drug side effect? So I think getting the help from the pharmacology like colleagues would be important to see like what's the expected timeline of this side effect. Probably this is too early for that. What do you think, Dr. Singh?
Yeah, I think I've not experienced this, but I think with the devastating effects, I guess, this patient definitely has gone into shock. The liver with the signature pattern of the liver enzyme elevation definitely points towards shock. And where could this shock be emanating? I think the organ at the center of this case is the heart, and it's being assaulted by the thyroid. Treating the thyroid, we haven't really treated the heart. If you think we're trying to control the heart indirectly through the thyroid, and the heart may have become compromised. In what ways could it become compromised shock, cardiogenic shock could develop, arrhythmia could develop. So I'm just wondering if this is just a culmination of that. Treatment in itself, yeah, it could cause instability. As we all know, you have a patient in acute congestive heart failure. You do not give them a beta blocker because you actually may worsen and put them into cardiogenic shock. Are we looking at this kind of a condition? I'm not sure at this point, but I'm glad they're in the ICU. They're getting critical care, and hopefully at some point they will reach some stabilization and be able to exit the ICU. Any other points, Kirtan, before we hand the mic over
No,
to Hemant?
I think that's excellent. Maybe Himud, you can give us all the data till the final, and then we can discuss once more. Yeah, thank you.
Yes, so all those HIV, COVID, hepatitis, CMV, everything was even like the ANA and double strand DNA, everything was negative. And the hepatic toxicity was because of that we switched to methimazole, and then it give persistent diatoxicosis, so we start to have a plasma pheresis, and then and the patient was going to have a final way to heal this patient's symptoms. So give us the final this way to solve this patient, and also I will give you a diagnosis of this patient.
Dr. Singh, go for it.
Yeah, I think it's a very wickedly difficult thyrotoxicosis to control, and occasionally this can happen. I can't really give you a diagnosis of what this could be, but I think we're on the right path. The treatment is necessary. And you had mentioned other causes. What could actually trigger the thyroid storm? Infections could do it, medications can do it, withdrawal of medications, thyroid medications can do it. So here I'm not sure. I don't have a signature of infection, say. Could there be an infection there? I can't say so, but you would do your due diligence and look for possible trigger for this episode. Anything come to mind, Keaton, before we
No,
go
I
to
think,
the
Dr. Singh, I agree that maybe it's not more of a diagnostic dilemma here. Maybe it's more of the management dilemma. So, like
yeah.
in general, you look at the medications and sometimes even the scans. Like, let's say if someone comes in the hospital and gets a CT scan for like a random reason, and then they go into thyroid storm, then it can happen that because we know with the CT scan, you give them iodine, right? And then people can get like iodine into their thyroid, and what if they have one tiny like nodular goiter which was active and which was just waiting for thyroid to like iodine to come in the body. So that is like known as like the Jod based dough phenomenon, right? But it's very rare, and in our case we don't have that, and that usually happens in people who have like subclinical thyroid disease and they go into like the overt thyroid disease. In our case, we already have a very good story for the thyroid disease, and doesn't look like this patient received any CT scan recently. So I think triggers, it's just the Graves' disease probably. And also like in the enzyme pattern, like as you were saying, that could this be hepatotoxicity or not? And it's very hard to say. But if you look at the AST ALT pattern, it was like more than 2:1. And we know that when the AST ALT pattern is like in that figure, like 2:1 or more, in the right setting, it could be suggestive of cardiogenic shock, because we know that when there is congestion and when there is ischemia, you release AST more than ALT. So it could just have been the shock itself, but it's reasonable to swap the medications and go for a safer alternative. They did the plasmapheresis to remove the excessive thyroid. And I think even if plasmapheresis doesn't do the trick, the last thing is you just remove the source, right? You just remove the thyroid gland itself. But what I'm thinking is that if the patient is so sick, then how would you end up doing the surgery, right? So that would be the trickier aspect, because in refractory thyroid storm, the only thing which works is the thyroidectomy. So curious to learn from Moon that what did their team end up doing? Yeah.
Yes, so once the patient was a little bit more stabilized than this, yeah, the final way to help this patient was total thyroidectomy. And so operative findings showed the pathology was diffuse toxic goiter by Graves' disease. So the patient went through a lot of difficult time, and finally, like 1 month later, the patient got better. But yeah, went through a lot of like intubation, extubation, and like a lot of shock and like Yeah, but then after the thyroidectomy, she got a little bit better gradually. So the diagnosis is a thyroid storm due to Graves' disease, complicated by cardiogenic shock.
Wow. This was a case of a wickedly toxic goiter. I've never seen anything like this, and it's amazing what you've outlined the treatment of this. And Kirtan was right. At the end, you have to take the thyroid out because nothing's working. The patient's just becoming unstable and more unstable, and ending up in the ICU and requiring a balloon pump and everything. Plasmapheresis. I've never seen a case like this, but that's why I come here to learn. So I definitely learned a lot today. I really appreciate you bringing this case, Heman. Kirtan?
Yeah.
Yes.
Yes,
Kirtan, go
sure.
ahead.
Yeah, no, sure, perfect. So like I just wanted to like emphasize like the teaching which we did, like if we like, take like the main teachings from this session. So first is like in the first aliquot we said that how context is very important, that you think this is heart failure, you see the word pregnancy and immediately you start thinking, could this be postpartum cardiomyopathy, right? But we always have to take a pause that does this person take drugs? Probably no. Does this person has like tremulousness? Does this person has like exophthalmos? And then turns out patient had that as well, right? So it's very important that you get the one-liner, you try to do the type 1 thinking, but you also want to do the type 2 thinking, that what can actually happen in this person, right? So that was the teaching from first aliquot. And then in the third aliquot, we discussed all about that AFib, that when to manage it, when not to manage it. In general, we don't run for rate control unless there are exceptions, which includes like hemodynamic shock along with constrictive restrictive physiology, severe mitral regurgitation, or you have, in our case, excessive sympathetic storm. We talked about how you want to do the radioactive iodine uptake scan if possible, not always. How exophthalmos is a unique sign of Graves and not any other kind of thyroid excess. And then in the management, we talked about that very important that, and Himun highlighted, right? They gave hydrocortisone as well. So you want to give them steroids, is absolutely essential. And then if the standard medications don't work, try to remove it, like plasmapheresis. If that doesn't work, remove the source, right? Remove the thyroid itself. So it's like such a beautiful journey that if someone sees the whiteboard, it would seem like a simple case of thyrotoxicosis. But if you just put yourself in the place when the first aliquot is running and you are in the front of the patient, it may not be that obvious, right? And then in the end of the case, when you're in the ICU taking care of the patient, again, you would be like kind of stumped, right? That like, hey, what's going on? Patient is not improving. So kind of a simple case looks like, but it was not simple. It was like very educational. And I will also read more about thyroid storm. And maybe we can ask Himun that how was it for her to take care of this patient and what did she learn from this? Yeah.
Yes, more than anything else, like I just learned actually I'm in CCU, so like interesting is I learned how to understand intra-aortic balloon pump. So like like cardiogenic shock person, right? What we want to do is like aim to reduce afterload to improve forward flow and maintain coronary perfusion. So I learned in this case like the intra-aortic balloon pump is not really healing the heart itself, but it's like helping. So the balloon is placed in the aorta and it inflate and deflate with each heartbeat. So during diastole, when the aortic valve is closed, the balloon inflates, pushing blood back toward the coronary artery. And then, it helping the coronary perfusion because the aortic valve is closed, so it goes to the coronary perfusion, increasing myocardial oxygen supply. And during systole, the balloon deflate, it acts like a suction, like it decrease the afterload and allow left ventricle to eject blood more efficiently. So like, I mean, learning all those intra-aortic balloon pump or ECMO, and those are very interesting for me. But
Perfect.
yeah, of course, interesting. Thyroid storm is interesting, but the process of how to take care of patient, yeah.
Perfect. Thank you so much, even for highlighting the key physiologic aspects of IABP. That's awesome. And now maybe we can pass the mic to Manaswini for the absolutely wonderful teaching points. Like the whole whiteboard is filled. So please, Manaswini, teach us. Yeah.
Hello, everyone. Love the discussion, love the case. Got to learn so much. Just wanted to share some teaching points. So we started off with palpitations. Initially, we think of arrhythmias and in the heart, but it's important to also note that it may be due to medications, drugs, coffee, anxiety, and if there are red flags like chest pain, or hemodynamic instability like dizziness, or if there's a compromise like CAD or ACS in the patient, cardiovascular compromise, or loss of consciousness near syncope, or even family history of cardiac death and arrhythmias in the past. All of these are important to note, and these are red flags. And we can also have mimics of palpitations, which is which is important, which is maybe because of the organs neighboring the heart, like esophageal spasms, reflux, hiatal hernia, or twitching of the intercostal muscles. So that is regarding palpitations. And shortness of breath, maybe two main points to see is whether if it's on exertion or rest. But it's important to note that one may overlap the other and in end stages, so it may not be as helpful. So we look for orthopnea and PND to see heart involvement. And it's important to note the context, which is age and demography, and the examples given for each age and demography, and how different each example, the reason for shortness of breath would be. And if it is pregnancy, it is important to not jump into conclusions, and important to see if look for any meds, if it's a pregnancy associated or not. And if there is heart failure in a young patient, it's important to note for meds which may be antipsychotic, antidepressants, or antiarrhythmic drugs, or any recreation related, or it could be recreation related. Then we spoke about tremors, which is due to excessive sympathetic stimulation. And in our patient, the patient had tachycardia and palpitation. And in young, the most common is probably due to drinking coffee or energy drinks. And that may be due to excessive sympathetic stimulation. The second would be chronic diarrhea, where sympathetic stimulation causes increase in motility and secretions. And it could also increase catabolism, which causes weight loss. If there are no particular red flags, we think in the lines of endocrinology or immunology. When we see AFib on EKG, it is important to ask a question whether if it's valvular or non-valvular, and doing an echo will be important. And if the heart rate is more than 10, more than 100, we think of rate control. And it's extremely important to note that if he is symptomatic or uncomfortable or hemodynamically unstable, it is all the more important to control the rate. But if we see, in cases like constrictive pericarditis, restrictive diseases, or MR, where it is we see that it is dependent on the last atrial kick to maintain perfusion, it is suggested not to give a beta blocker just to ensure rate control. And we see that postpartum eclampsia can affect the heart in various ways. There may be changes in the myocyte of the heart, and so on. So, but when we talk about in our patient, when we see goiter, it may be multinodular, and if it's toxic, it can cause cardiovascular compromise, and we can also hear a bruit in cases of toxic multinodular goiter. And thyroid changes the myocyte in the heart and eventually may cause cardiomyopathy. We see that a heart with AFib may also suffer from channelopathies and fatigue. So it is important to also note for rhythm control in such patients. We also went on to see the mechanism of excessive thyroid hormone, where it could be due to excessive formation, like in Graves, where we have antibodies raised, or due to release of thyroid and follicles from the follicles, like De Quervain's in postpartum thyroiditis. And here it is important to note that antithyroid medications like methimazole and PTU must not be used because it might worsen the condition. And the gold standard to differentiate the two would be radio iodine uptake scan, where it lights up in a Graves' disease due to increased iodine uptake, but not when it's postpartum thyroiditis. If it is thyroid storm, to objectively note it, there is a score called BWPS, Worth-Tox Key Point Scale score. And if it is more than 45, we definitely think of thyroid storm. And in our patient, it was much more than that. So we think of we know that it is thyroid storm. And it is important to dampen the sympathetic drive in such patients, especially with propranolol, which also has an added mechanism of converting T4 to T3, preventing conversion of T4 to T3, which is T3 being the active form and decreasing the effects of the hormone. And it was another point brought up was thyroid and cortisol are like buddies, and if thyroid, if given in adrenal insufficiency, may cause clinical adrenal insufficiency. That was a case. And we also see in our patient we see deranged LFTs, and it may be due to shock liver, which is ischemic hepatopathy, but it may also be due to toxicity due to the antithyroid drugs. And in our patient, the time course favors a shock liver, and AST more than ALT is also seen in a shock liver that may result in due to cardiogenic shock. And in acute heart, it's important to also note that in heart failure, acute heart failure, giving propranolol may worsen it and may worsen the cardiogenic shock in the patient. It's finally coming to the management. We know that we learned that thyroid toxicosis is important to decrease the symptomatology. Giving beta blocker to control the heart rate and symptomatic surge. Also start the patient on steroids and to rule out the underlying cause, which may be infections, medication, withdrawal, or Graves' exacerbation, which is the case in our patient, and go on to plasmapheresis, and the definitive management would be removal of the thyroid.
Perfect. Thank you so much, Manaswini. Can't believe that you have done this only handful of times and you did such a thorough and comprehensive. Also, thank you for that. Thank you to everyone for joining. Wish you, Himun, that you enjoy your CCU rotation. Thanks to Bayan for scribing, and hopefully she enjoys her pediatric rotation. And Dr. Singh, maybe he will give nightmares to other people by doing the sim lab. So thank you for joining, Dr. Singh, and see you next time, friends. Take care.